to share this work that I've been diving into for the last 5 years with you guys. And now that I've gone into it enough, I feel like, gosh, I just found a secret, and I can't do this by myself. I really need my tribe. So I know a majority of you guys, y'all are my tribe. And so we're gonna do this, and a lot of things that I'm going to be presenting today is stuff that I've done in the past and share with you the road in which I've gotten here. And what I'm hoping is that you'll look in that road that I'm in, and I think some of it, a lot of you are gonna identify and say, oh, I got that, I went through that. Maybe from an orthodontic perspective, for some of my ortho friends or myofunctional therapy friends, you may not kind of know what my journey is, but you have your own journey that's very similar. And I really want to share that journey with you because I want you to understand why this work is important. And if I don't share with you how I got here, you won't understand why it's so important. And it'll help give you an overall picture of what's necessary for us to do this together, okay? So the way that we're gonna structure our program is we are going to have, I'm gonna kind of take the past and take you to the present of what we're doing now, and that way you can envision how your practices and what you're trying to accomplish in your practice fits into the scheme of things. And what else is there that you would like to do and how you see yourself in the process. And then, so it's a rough overview of postural restoration, full mouth rehab, airway, TMD, all these things that, we've all been working on so hard. And then the second half of our evening, we're going to come together and just kind of share who we are, what we do, and what's important to us, and what you guys want to get out of the program. Okay, so we'll do that the second half. And then Mike and I have a surprise for you that we're flying in. So we didn't even advertise this, but you guys are in for a treat. It's like you got 2 for the price of 1. Anyway, I won't say until it comes. Until it comes. So postural considerations in dentistry and airway management. I know a lot of you guys are doing airway right now, and so this is not the airway that you may think it is. And so it's exciting, and I wanted to share with you my journey from being a single tooth dentist to a to being a dentist that takes the whole body approach to dentistry. And I know that all of you doing biological dentistry, doing airway, doing, Vivos, DNA appliances, TAP appliances, all of that, you guys probably can identify with some part of this. I'm pretty sure none of you guys are single tooth dentists, but that's how we all started out, right? Coming out of dental school, you go in and you identify, and you're like, well, what do you see? We see a crack and leaky amalgam, so we'll make a tooth in a little clap thing. What do you call that? A ristillator, right? And then as we go along and we start really looking at teeth, we start seeing things, and we're like, well, how does that make sense? What's that little thing? How did it get there? How did it get there? Why is it there and not there? And not there? Myofunctional therapists, I know y'all are seeing this, but none of us saw that back then, right? And what about this? What's that? What the heck happened? And how are you going to restore these darn things, right? Are you just going to go in and do some class 5s, and when they come off, what do you tell your patients? It's the bonding's fault. When one by one they come off, or that day was my assistant careful enough to dry off. I mean, we all have experienced this, or sensitivity on these bonding, and preempt the patient, said, by the way, you go home, you can be sensitive for about 6 months, but it's okay, you'll get over it, right? Do you remember all those days? If you didn't do it, then you heard them telling you. Patients will come in and tell me, oh, these are the white fillings. My last dentist told me it should be sensitive for 6 months. I don't want the white fillings anymore. They hurt me. Because everyone that I had are now crowns. Do you remember those days when we didn't know enough about bonding and every composite filling became a crown because there's apparently a crack in it that was a hairline crack that we didn't see. That's why you're sensitive, so we're just going to crown it, right? Those days. What about this? Do you guys remember? And how are you going to restore this? I mean, you obviously have worn down dentition, missing teeth. This probably has collapsed bite because you can see all of that there. But when you were not really coming out of dental school, you're like, if I cap all of these, how is that going to turn out? And so sometimes, have you guys heard of the unconscious incompetent? You're unconsciously incompetent, and then you learn some things and become consciously competent, and then you're unconsciously incompetent. First, you're conscious competent, unconscious incompetent, right, Mike? And then you become conscious incompetent. I know I don't know crap, right? And then once you figure out you know what you don't know, then you figure out, okay, now I know what I'm supposed to know. But then the minute you go there, you go back to the unconscious competence. So it's like a cycle. But in this case, what questions might we ask ourselves when we see more generalized complex presentations? Will the work I do here hold up over time? And then there's a lab. We can always blame the lab. Is the lab going to be strong enough? Are they good enough? Let me find an expensive lab enough to be able to do this, right? How do I know how much to open up a bite? Do I let my lab determine that? Do I have the skills to handle this case? Maybe that little voice inside you starts asking the real questions. Is the problem this patient is blaming me for, the problems this patient is blaming for makes no sense. Are they imagining this, right? So a lot of dentists that haven't had the training to do full mouth rehab, and they go in and do mouth rehab anyways, they end up with problems, and because they don't know what they don't know, they'll blame the patients, and you know about it because they land in your office and you hear all these things that they've experienced, and it's quite sad. But I think sometimes, for me, the answer is in the questions that we ask ourselves most nights when we're up thinking about these cases. Is the dentist a mechanic or a doctor? Are we dental technicians or are we actually doctors? Are we fixing teeth or are we caring for people? What drives us in either direction? You guys are welcome to answer, because for me, for a while, after doing so many fillings and crowns, you feel like a technician chairside, right? And if you really care for people, it does push you to another level, except you got to spend a lot of money on CE, you got to study this stuff, you got to learn to hone yourself, and then you got to go back and convince your staff that you know more, you want to do more, and get them to do more. I mean, it's a lot of work to be a doctor and not just fixing teeth. It takes an entire team to do that. You can't do it yourself. I mean, your team, I mean, the kind of training, the amount of money and time that you spend in your team. To me, what drives us in either direction is leadership and heart and passion, right? It's hard. We all know it's so hard to try and go one direction because the entire world pulls us back to the other direction, right? So at that moment for me, I knew that I didn't know what I didn't know. So I went to the Pankey Institute, I went to Dawson, I went to Spear, and I speed tracked. I think I did 400 hours the first year that I realized that I just didn't know anything to do, anything I wanted to do. I did 400 hours, and since then I've done about 200 to 250 hours a year. So because I went there, I became occlusion aware, okay? And learned the definition of centric relation, but it baffled me because according to Wikipedia, at least 26 different definitions of centric relation has existed since 1930. So I'm thinking, what the heck? You know, where do I start? Little old me, just out of dental school. How am I gonna get a grasp on this, right? What I do know is what it's not. Do you guys remember in dental school when they told you to push the jaws back? And you're like, that's so uncomfortable when we did it in lab to each other. Are we gonna set all teeth to that? It didn't make sense. So when I heard centric relation for the first time, I completely rejected it. And I searched and I did all kinds of courses. And you know, finally when I actually went to meet Pete, and he explained that it wasn't about pushing the jaw back, you know, that's when I realized, okay, we're onto something, and I think I can take this explanation home and actually do something with it. So centric relation, for those of you, just a review, is the relationship of the mandible to the maxilla when properly aligned condyle disc assemblies are in their most superior position, not distalized, against the eminentia, irrespective of tooth position or vertical dimension. Those are a lot of words, right? So what does it really mean? It's about this condyle being superior forward, not back, and it's in a stable place. And it's talking about, oops, sorry, right there. And so I read cover to cover functional occlusion. I've probably read it 3 times in the first 2 years I was doing this. And my office slowly became a comprehensive joint-based occlusion, doing a comprehensive joint-based occlusion dentistry, because I learned Dr. Pankey's 3 rules. Rule number 1, the condyles are fully seated in the fossa. All the posterior teeth touch simultaneous and even, with anterior teeth touching only, lightly touching. The reason I want to share with you this, not because I want to teach you occlusion tonight, I kind of wanted to get an overview because these are important concepts that will lay the foundation for what we're about to learn with postural restoration tomorrow, okay? And when you squeeze, neither a tooth nor the mandible moves in a lateral direction. So it's a solid centric stop. When you move the mandible left, right, forward, back, any excursions, no back tooth hits before, harder, then, or after front tooth. So basically when you go side to side, the front teeth separates the back teeth, right? Cuspid rise, which is actually not true when you find out. Because later on when I started putting people in cuspid rise, I don't know if you guys have done this, you start putting people and equilibrate them and take them in a cuspid rise, there's a number of them that go back to group function. It's like, why the heck do they do that? Why do they do that? Have you guys seen that? I have the answer now, and I'll let Mike tell you tomorrow. It's so cool. All these little things that you do because you follow the books, right? You followed everything you ever learned from the greatest people, and then you start seeing things different. And you're like, did I not do it right the first time, or is there a concept here I'm missing? So, comprehensive joint-based occlusion dentistry. Key components of a healthy, stable occlusion starts with healthy joints in centric relation, proper anterior guidance with no muscle symptoms, and honoring the envelope of function and accommodating the envelope of parafunction. So you look at that, right? And so there's tons of other little corollaries to that, but from that, I started learning how to guide the jaw in centric relation. Pete used to say, manipulate the jaw into CR. And if you're manipulating, to me, that doesn't sound like it's a natural position. It is more of a forced position, right? So I think when we started going to Pankey and I started becoming a faculty there, we all spoke about that. So at the Pankey Institute, a group of us decided we're no longer going to use the word manipulate. We're going to say guide. So comprehensive co-discovery exam. So this is, to me, for any practice, if you want to share with the patient what you know, and engage them into what you're doing, having a co-discovery process is everything. And so when Mike starts teaching you the exam process, you're going to see how everything he does is absolutely co-discovery. And for those of you that have come and been under Mike's care, you actually know what co-discovery is, because you actually get you engage with your own body, and you get to diagnose yourself because you're seeing objective tests and what your body is doing. So we do the same thing with dentistry. Back then, this was my lightsaber. Anterior deprogrammer, I use that to feel on muscles. So I have patients feel on their own muscles so that they can engage within themselves. Neela, right? It's our lightsaber. We do the Blumenthal method and do rotation and all that. It's great. And I still use it a little bit, but now that I know what I know with postural therapy, this is actually almost against the law. So many things I've learned. And as you go, you'll see why. And if you're doing it right now, it's okay. Don't freak out. Keep doing what you do, knowing what you know. You're not hurting anybody. But you'll start seeing how this is so elementary compared to when you start incorporating the body. There's so much more you can do. This is almost just anecdotal, right? So at that point, I started doing whole mouth and learned how to take beautiful photographs, handing the patient the mirror so they can get into their whole mouth, or doing your intraoral cameras, inviting them into their own mouth so that you can have a discussion with them. That's really important, rather than just calling out to your dental assistant and then presenting a treatment plan that they need. Our office philosophy has always been to let the patient form their own treatment plan, because whose treatment plan are they going to accept, yours or theirs? So if you arm them with enough knowledge to come up with their own treatment plan and guide them through the process at the end of, so usually when I go into a review of findings, I don't have a treatment plan. We sit there and say, what did you think since the last time that we got together? What's important to you? And how is it important to you? And so, for example, if somebody comes in and says this front tooth is important to me, but you see issues going on with their bite, you still go back to what's important to them, but you can tell them these issues in the back is going to cause the things that's important to you to fail. So is it okay with you if we do a more overview of what's going on with you? So you engage them with honoring their chief concern first, and then you have an opportunity to tell how your concerns affect their concerns. So that's to me very important part of that. And these are the soft skills that I think if you decide that you're going to do airway, TMD, it is complex stuff. You gotta have the soft skills. You have to set your exam process. You have to set everything up in your practice, including your team, to speak the same language as you do in order to make the process conducive for patient understanding and their growth. And so you guys all know this. You guys know what I'm talking about. I mean, it's layered learning, right? You get higher clinical excellence. You got to have higher behavioral knowledge. Higher clinical excellence, higher behavioral understanding of people. So I call that layered learning. So I went from a clap, Arista later type of dentistry to a truly mounted models on semi-adjustable articulator. And my study club with Todd Shire sitting back there makes fun of me all the time, because right now we have all this cool digital imaging, but they said, don't tell Alice Lam because she still likes her articulators. So with DSD, it's great stuff, digital, it's great stuff, but every time that I run into problems with it, I was like, can I see those mounted models to see if they look like what I'm seeing on DSD? Because it may not work. I always know this has been tried and true, and I have yet to be able to get away from these articulators, especially now that I'm doing PRI. This articulator is my lightsaber. So as I go along, as I became a more sophisticated dentist, I had opportunities to work with really amazing patients. And I want to share this patient with you. Her name is Karen. She still haunts me to this day. It was a very successful case, but there's a reason why she haunts me. I'm going to share that with you. Okay, so here's Karen. Her initial chief concern when she came to me, I'm looking for a dentist like Dr. Gallerano, my son's orthodontist, who would take time to listen to me and provide me with quality preventive care. Yes, we're the right place for you, right? Preclinical interview, that's her. Medical history, pretty benign for the most part, right? And then I learned a very powerful question, and you guys are gonna like this question. It's gonna change the face of your practice. Other than what shows here in your health history, how do you feel about your health? That opens up doors for a totally different conversation, okay? How do you feel about your health? It's a totally different question because people with perfectly good health will come out and cry and tell you they don't feel good, they have pain here. You know, you really get into, you know, you don't get to do complex dentistry until you get to understand people's dreams, desires, fears, hopes. That's the level that you get to with this question, okay? And so I found out her real chief concern. I can't eat, my jaw hurts, my bite's very confused ever since I had orthodontics. I just want to be myself again. This was actually what she came for. But because she has already seen 3 orthodontists, an ENT, 2 oral maxillofacial surgeons, a general dentist, and a neuromuscular dentistry specialist, all of which deemed that she had psychiatric problems, she was afraid to tell me the truth because she was afraid I wouldn't treat her. Okay? So we took time to grow a relationship with her. I mean, her teeth were, for the most part, in really good shape. She had 1 root canal. Other than that, why should she have any issues? Joints healthy, you know? Yeah, she's got a little bit of flattening of the condyles, but really not a big deal. Back then, I didn't know anything about airway, by the way. So we didn't talk about airway. You know, mounted her models and started out with splint therapy, okay? This case, I did an upper splint because she had a lower fixed retainer. So I figure, okay, it's a bite problem because she was slightly class 2. It didn't have really good cuspid rise. She had a CR to CO discrepancy with a hit and slide. So we figured that's what it is. We put her in an upper splint, adjusted it, lines in the front, dots in the back, everything's good. Yeah, her pain went away. How much? 90 to 100%, 90% of the time. So to me, that's pretty successful at that point. Then we decide, because we tested it, we used splint therapy to test out a bite, okay? And presented her with an occlusion that we think will work, which is cuspid rise occlusion with nice centric stops everywhere. And if her pain subsides, you know that anything you do to the teeth, you place in the same schematic that it's gonna work. And so I went in and I balanced her bite based on that. I did my trial equilibration, and we went in, took out balancing interferences, protrusive, got her CR equals CO, everything's nice and clean. And then she says, I have this tetracycline stained teeth. My bite feels so good. Can we do anything about it cosmetically? Well, because she's slightly class 2, remember I said slightly retruded, if we were to give her veneers, we also would accomplish in getting her nice cuspid coupling and good, you know, anterior guidance. So it justifies that with the tetracycline stained teeth, it justifies that. So I went in and did something that we learned at Pankey called a trial smile, where you just take a bunch of expired composite, is what I use in my office, roll it up into balls, and you know, give her a trial smile. So that took me about maybe an hour to do, but it's basically Play-Doh on teeth to test out, and she could feel, at that time we could get cuspid coupling, so great, right? And so from that we took molds on that, used it to provisionalize, and prep day. We finished and we test drove her with occlusal scheme, checked for crossover, no interferences on these laterals, crossover into centrals, looks great on the right, looks great on the left. Final restorations. Victor's not here, but I wanted to showcase his work. Victor does beautiful work and got even protrusive, even shear protrusive, same thing. Good cuspid rise, she's good to go. And I was able to achieve comprehensive, occlusally sound cosmetic dentistry. There's her in her trial smile, provisionals, to her final restorations. I am now a comprehensive cosmetic dentist. Yay! It was so awesome, right? It's a good feeling when you're able to accomplish something when somebody came in afraid to even tell you they're in pain. And this case landed me on the cover of New Dentist ADA, of the magazine, because I presented this at Pankey, and I don't know, somebody there was part of the New Dentist, so they said, will you get your patient to, can we call your patient for an interview and showcase this case on the magazine? I said, great. So I have it on my wall now. But I will still tell you, I'm giving you hints. This case still haunts me to this day, okay? At that point, I felt, I'm occlusion proficient. Yay me, I'm so excited. I can do a lot of cases. And then I meet cases like this. What do you guys think? Healthy or pathologic? Isn't it kind of obvious? Healthy or pathologic? Malfunctional therapist? Deanna? Huh? We dentists don't think so. Okay.
Rachel had two of the first one you showed just today.
Yeah.
People today with the most massive rare god-awful berry.
Yeah, healthy or pathologic. Healthy or pathologic, the same people, okay? Which one needs treatment, you think? This guy comes in and says, I eat fine. I have no pain and my teeth have always been short. I don't want any dentistry because anything you do could mess me up. This guy, this woman actually, says, my teeth are sensitive and my bite doesn't feel right. I have headaches and jaw aches that radiate to my neck and shoulders every day, and the last 3 doctors think it's not a dental problem or it's actually in my head. So what do you guys think? Which one needs treatment now? And what the heck do you do with this, with all the restorative dentistry that you need? Cap every single one of them and put in full mouth reconstruction, because this patient was offered that. What determines a pathologic bite? We all have our own ideas of it, right? Teeth only? Obviously not. I mean, this case just cases like this keeps me up at night during the time that I was going through this. So what questions might we ask ourselves when we see more unusual complex presentations? Will my restorative work remove or cause pain? I know you guys have thought of that, right? When you see like these weird symptoms, you're like, God, if I enter this, am I entering like a black hole? Does a bite discrepancy really cause TMD? How do you determine the likelihood of TMD symptoms that come from someone? Can you determine that by teeth only? The problems this patient keeps obsessing over makes no sense. Are they imagining this? I'm serious. Every time I think this, I realize, crap, I don't know enough. Because it's never in their head. The minute we say it's in their head, we need to be searching for answers. And again, this was a Post-it note that was on top of my computer every day that I look at. And it answers a lot for me. Are you a dental mechanic or a doctor? Are we fixing teeth or caring for people? What drives us in either direction? And this is what gives me juice to push the envelope in the ways that I have had over the years. So I went to Pankey again, took more courses. By then they have corollary courses on TMD. Droder started showing up John Droder started showing up. During that time, I met Neela Patel. She and I became the queen of TMD and CT scan. We were reading it before anybody was even taking it, right? So I became aware now that it's not just about the tooth. The occlusion matters, the joint matters, but the head and neck matters too. We started palpating muscles. We learned about the parts of a healthy joint, You got your condyle. We learned all these fancy terms of what comprises a healthy joint. Posterior ligament, you guys recognize all these if you guys don't recognize this, you have no business expanding an arch. Sorry. You'll get in trouble, I promise you, because it's going to affect this. Start palpating muscle symptoms, and I started palpating and learning about all these muscles, omohyoids, scalenes, splenius capitis, all these muscles. I even took three actually. We took 3 courses taking out the head and neck human cadaver again to go through and look at the joints, look at the muscles. And this in dental school, we did it to pass. This time I really wanted to understand function, okay? Learn the difference in muscle symptoms and what they mean. If it's tender, what does that mean? If it's limited range of motion, muscle splitting, different ways muscles present themselves. Irregular movement and deviation, asymmetries, abnormal size, and uncoordinated timing, okay? And then, when you're going through all this, your chart changes, right? You start taking all these notes everywhere, and your comprehensive exam gets longer and longer, and your front desk person gets so mad at you because, there's no way you can take 2 hours for an exam, and you're doing more because you're learning more. But, sometimes learning more and doing more doesn't mean you really know what to do about it. Okay, so I don't know if y'all do that, but sometimes I just record in the beginning just to make sure I don't miss anything, but then I'm looking at the data and I'm thinking, what do I do with this and how does it translate into the work that I do? I don't know if y'all experienced that, but I did, but I didn't want to miss it because I was taught it, so I better do it, right? And then learned about joint breakdown. I went to see Piper, and he talks about bruxing and clenching and traumatic occlusion causing microtraumas, which causes joint overloading and inflammation of the joint space. You learn this cascade of action that occurs, and you get damage to the posterior ligament that leads to laxicity and disc displacement, which leads to discalization of the condyle because this disc is possibly anterior displaced. That's why you get locked openings. And when you look on x-rays, you see degenerative changes in TMJ, you know that it's because of this from bruxing, clenching, and traumatic occlusion. So here's a patient that I started seeing when I started doing craniofacial pain. You can see I started taking more full photos, CBCT on everybody, and you can see on this particular patient, Rhonda, her joints look like Swiss cheese, and look at this one compared to this one, right? So I put her through splint therapy, and my restorative practice became almost a TMD practice overnight just because I wanted to do good cosmetic dentistry and I needed to learn how to put a bite in the right place. So I started making splints, and I started making them myself because one of the things that I want to share with y'all that is, if I don't say anything this entire 2 days, I want y'all to remember this. You cannot make a splint that comes from a lab, pop it in a patient's mouth, and think that you're not going to cause a problem. It is absolutely so imperative that you reline this in the mouth, okay? If you're not mixing and relining in the mouth and creating a rotational seat on it, you are going to cause muscle issues that you don't think about. You may not cause it for every patient, but maybe 10 to 20% of your patients that say, I don't like wearing the splint, it feels fine, but in the middle of the night, when I wake up, it's on the floor or thrown somewhere around my bed. Or if they wear it and they said, I don't feel, it feels uncomfortable to me, I can tell you it's because you didn't reline, okay? Because when we take the mold or take the impression, you actually flex the jaw. And when you seat it, even if you put those little ball clasps and they say that they remove the undercuts, it's truly never really removed. Because if they remove all the undercuts, it's going to jiggle just a little bit. If it jiggles just a little bit, your muscle's going to splint it in place and grind more. If it seats too nice and snug, that means that it is flexing the mandible, which causes muscle spasms. And so you're going to have pain right under your zygomatic. Right, Neela? I mean, we have to. I mean, the minute I started relining, I never had complaints again about patients. Well, except Karen. Okay, so I did all kinds of stuff. So this is, John Droder showed me how to do this. And this is something that I've looked back on. And I was pretty proud of it at the time, but now I look back and I'm thinking, Deanna, what do you think of this palette? Right here. This is a maxillary appliance that I used to make for my patients that get locked jaw. And I'll tell you, it worked beautifully. In one appointment, I'm relining this, because I reline all my splints. I put plastic on here. I seat it up, and they go from 25 millimeters to 35 millimeters in 10 minutes. John Droder showed me how to make these. And so we make it in our own lab. It works. It's awesome. Okay? But today, I no longer make this. Okay? I charged a patient, I think, $2,200, $1,500 to $2,200 on this, depending on the severity of the issue. And now I look back and I'm like, oh my God, I wasted their money. I didn't need this. I wasn't, but we'll share all of that. Okay? Lower splints. I did Dawson splints, Pankey splints, Tanner splints. Have y'all heard of Tanner splints? They're index splints, and you start them where they're at, and you figure out their bite. And if you go Tanner, you literally could be in a splint black hole for a year and not do a single restorative dentistry. I couldn't get the Tanner splint other than, if you get wobbly joints, these index splints are great. In a year's time, I might make 2 Tanner splints. So in my hands, I didn't find value in it. So now I know why. So I'll explain all that, because we have Pankey study clubs that I'll tell you, they'll spend 20 years meeting with each other just to talk about Tanner. That's what a big deal Tanner splints are in the world of Pankey. Okay? I mean, what we know now, I think is going to rock Pankey's world. Anyway, and even with the lack of what I know now, I actually had really great success. So I'm not going to downplay some of the stuff that we've done for our patients. That same patient that you saw, Rhonda, look at her joints back in 2014. In splint therapy alone and just being in a good splint. Here she is in 2019. Look at the joints. Look at the difference. Mm-hmm. So you guys and she didn't have a very good bite. She didn't have money to go through full restorative, so we kept her in a splint, kept her healthy, infection-free. So if you do a well-done splint, relined in the mouth, the patient could benefit from it greatly, even if you don't do postural restoration, because look at the results. Okay? So at that point, I consider myself a proficient at head and neck. When you get results like that in your pocket, you feel pretty good about it. And along the way of reading all those x-rays, you come across, and now Airway's in business. So I started working with Ron Prane back in 2005. I would drive like an hour to the Woodlands every week and just stayed with him, and I wanted to get into sleep, because at that point nobody knew that sleep had anything to do. Back then, no one cared about sleep or airway. Do you guys remember? Nobody cared about it. And so I joined with Ron Prane and Jerry Simmons in a study. We sent Jerry 650 patients who were avid bruxers. Out of 650, I think like 375 showed up. Out of 375 avid bruxers that showed up, 100% of them had sleep apnea or respiratory disturbance, really high RDI, respiratory disturbance index. So we realized there was a connection between sleep and bruxing. And then that's when, I remember during that time, me and Ron and Jerry were screaming to everybody at all these meetings, hey, we got to look at airway. It has to do with bruxing. No one wanted to hear it. I brought it to my TMD study club. Nobody wanted to hear about that. Remember, Neela? No one wanted to hear about an airway. No one wanted to do sleep studies. What does that have to do with anything that we do in dentistry? And so now, you go to any meeting, can you not hear about sleep? Any meeting, sleep's all over. So we became sleep and airway aware. So it's wonderful that we're sleep and airway aware because the majority of patients don't get this from their medical doctor. So what a value it is for them to come to their dental office and be able to be diagnosed with something that could severely hurt the outcome of the quality of their lives. And so during that time, as I was doing that, I did more splints, started doing more sleep studies, hooked up with all the sleep labs, sent patients. Some patients would go home with CPAPs if they needed to, if they were severe, or the other cool thing that I did was I started looking for, different modalities. This is an electromagnetic reprocessing unit that I learned about. It's called Beamer. I can't live without this in my practice, because I'll tell you, remember that Droder I showed you about unlocking a patient? And I would have the Droder, we had a cold laser. It would take us about 3 weeks to unlock a patient, or I'd have to put them on steroids to open it enough just to take a mold to even make a Droder appliance, okay? But with this appliance, with this treatment, it's just 8 minutes twice a day, which they come into our office and we open up the circulation in their joints. I literally can open a patient up in 45 minutes in my office. Since I learned this, I no longer use a Droder appliance. And the appointment for this was like $60 for the patient. So, you don't make money with $60 versus $2,000, but is this a value? Yes. Does it make sense for you to engage a patient into a long process and put them in agony? Well, are you a tooth mechanic or are you a doctor? You have to answer that for yourself. And when you stay in the path and you really do what's right in your heart, I do believe that you get rewarded by it. So I started, here's Ron, started hanging out with him, made all kinds of sleep appliances. This is a TAP-PAP, advance the jaw and put them in a CPAP if you don't see results. We did fun stuff, made it leopard skin. We had leopard style, we had zebra style for the women. We even had ones with fur around them, pink fur, really cool stuff. I know when I came to Ron, I said, these are boring. Women are gonna wanna look sexy in bed. So can we make them look cuter? And he goes, what do you think? I said, zebra, and put some fur around it. So we played with it, and that's how we came up with this. As we dive deeper into some of these complex presentations and patients come in, because it's not easy to sleep with a CPAP. It's even harder to sleep with a TAP-PAP. And do patients actually go through their whole lives and then you get all these jaw issues with it? Is keeping a patient in CPAP or TAP-PAP for a forever solution? Can I accept that as a forever solution for a patient? Because I can't. You just feel like it's limiting and there's gotta be more, right? How do I treat patients with mandibles in protrusion who now have developed head and neck pain? We can justify it and we can say, well, it's justifiable because we're saving your life. So doing this saves your life. And so the patient will come in and they're like, yeah, I know I'm having jaw pain and my neck's real stiff, but my life is saved, so it's okay, right? So I would have to make a patient a splint during the day to ease their neck and jaw discomfort because they're going to have to wear a TAP-PAP at night. Just didn't feel good. I was still so troubled by the solutions that I had for the patient. What's happening at the joint with these patients whose bites have changed even with the AAM aligners? I don't know if you guys have seen that, but they're saying, use the AAM aligners, the bite won't change. BS, it changes. And they're end to end, and they're having issues, and if you look at their head, it's forward. Okay, so we are making changes. And the trouble I had is even when I went to all these meetings, and I asked the brightest and most amazing, smartest clinicians, and I said, what is happening? Why is your jaw forward? No one could give me an answer. They give me answers like, well, it's probably distraction osteogenesis. The condyle probably went down and forward because the disc assembly stretch. I mean, I heard all kinds of case scenarios on why this bite was happening. And to this day, I mean, until I met Mike, I didn't know why, but now I know. And you guys are gonna know too why it's happening. Karen, 10 years later. I can't eat, my jaw hurts, my bite's very confused again. Can you help me like you did 9 years ago? I just want to feel comfortable again. She, 9 years later, this is 2016, okay? So she started getting heavy into politics, and you know 2016 was freaking stressful for everybody. She's obviously, a Republican and was working really hard for what she believes in. But because of the stress, she gained 15 pounds. She's hitting on the right side again on the splint, and the left joint's popping again. That's what she initially came in with, and now it's happening again. Mike, you're not surprised, are you? I was, because her smile looked pretty gorgeous, her face looked pretty gorgeous. Splint adjustments were done down to the minor polishing. I literally would take a polisher, polished it, and she could feel the difference. That's how much of a princess in the pea she was. But I couldn't get her comfortable past 2 weeks to as little as 2 days. What the heck? Why is this happening when I made her a new splint? Saw her for adjustments for 14 months. It was a black hole. She had my phone number. She was texting me every day. I knew I was going to get a text from Karen, but she was in so much pain and so desperate. I couldn't just leave her. At that point, I just didn't know what to do. And she went and saw a second opinion with another TMD specialist who told her she needed to get full mouth reconstruction and cap every single tooth in her mouth, that she would be relieved. And her husband was so desperate for her, he says, leave Dr. Lam. So she left. She left. I stalk her on Facebook to look at her face. Because I want to know. Now that I know what I know, I actually am thinking, I'm going to write her a letter and invite her back. I really am, because now I know, and I'll show you what I know. What questions might we ask? If the TMD principles are the same, why do I not get the same results in each patient? You guys have all experienced this if you play with TMD. Who has experienced this? Yeah, right? If splint therapy worked the first time, then why not this again on the same patient using the same principles? What am I missing? Were those principles really sound to begin with? Why did they work? Did I just stumble on and accidentally treated somebody and got accidentally successful? The problems these patients seem to obsess over makes no sense. Are they imagining this? Because I found myself thinking, she's imagining this. She needs to go see a psychiatrist. But I knew better. I knew I had to keep searching. So what does it take to become a TMD sleep and airway proficient doctor? What does it really take? I look at this again. What causes joint breakdown? The whole cascade. And I realized I was looking in the wrong direction because what we needed to look for was the other way. My questions were wrong. My question should be, what causes ruxing, clenching, and traumatic occlusion? Airway is not the only one, because who here knows of people who clench daytime. If you don't, then you're not treating airway and you're not asking the right questions, because we have tons of patients that clench daytime. How's their airway compromised when they're breathing and walking and not falling over? So what's bruxing and clenching? Is that just a sleep issue? No, there's no way. And then I go and I meet people like Christy Gatto, and then Karen and Angela tells me, are you looking at the tongue? Maybe it's the tongue. Okay, so I started looking at the tongue. I started measuring the tongue, and, you know, and I don't know if you guys do this, but you measure the tongue and then you have them lift up, and if it's about 50% or less, you know that they're tongue-tied, right? But how many do you have that don't seem tongue-tied, that have issues placing their tongue up? And then malfunctional therapists, you train their tongue to go up, but it won't stay up. They have to keep doing it. No, just like retainers, orthodontic retainers. Why is it that if they stop wearing the retainers, teeth start moving? Right? 20 years from then, it could start moving. So what questions might we ask to see more as we see more of this? How did the patient's bite change spontaneously? Or is it spontaneous? Can CR change? Have you guys ever had a patient that you know that you put in a perfect bite? I know you do this, Amanda, because you completely are so meticulous. I've seen your cases, okay? You and I have a patient like this together. She and I shared a patient, and I worked, and Amanda's like, you know what? I need a second eye on this because I don't trust what I'm seeing. You get her in perfect occlusion. I'm going to restore her, and then you check my work, okay? She and I teamed up. Guess what? 2 years later, she came back, her bite opened.
No, it did.
It did too. She started having issues. Her bite opened by 2 millimeters. And guess what I asked her? What did you do in the last 6 months? She said, well, I had breast reduction. That's the only thing I did different. It was during COVID and I had breast reduction. Could breast reduction have changed her bite? Hell yeah. Because I started asking other patients that I started seeing that your center of gravity changes, your head's going to change, it's going to change your bite. If you start seeing your work change and all of a sudden somebody's bite change spontaneously, start asking them questions about their bodies. Okay, so I started realizing, my gosh, there's a body component that could change my work. So usually when your work changes and you don't preempt the patient that things could change if something happens, when something bad happens, whose fault is it? Yours. But if you preempt a patient and something happens of what you preempted with, whose fault is it? They take accountability, right? So anyway, that's really important. Why do people's faces start looking more lopsided over the years? Have you seen that even in your own face? You started noticing your ears change position, your eyes. You got one eye bigger than the other. It's like, why is my face so lopsided? I look at my pictures, I don't look like the way I used to. I know I'm older, I've got wrinkles, but what does that have to do with my facial structures? And I have patients that come in and show me pictures and say, why do I look like this? And now I have pain. And I started connecting the dots and saying, you know what? All these people that are showing me their facial structure difference now live with pain. Is the pain causing their face to look this way, or is their face looking this way causing their pain? What's going on, right? So can a bite change after tongue release? Because I've seen that too. Somebody goes get tongue release and it comes back and their bite totally changed. You're like, what does the tongue have to do with the bite? Because I was told that if you get people in a joint seated position, it's bone on bone, that bite's not going to change. So why is the tongue, soft tissue, changing my bite? Right? If you know their joints in a seated position, they're biting down, are they going to be able to go beyond the fossa? Then why did their bite open? I couldn't sleep with these questions when I see it. So what does the tongue have to do with a bite? Okay. So I go to AES, American Equilibration Society. It's a big meeting about occlusion, TMD, comprehensive care. Didn't know back then, but Pete was giving a lifetime legacy lecture, Pete Dawson. He was up there. And I didn't know it, but that day that he gave that was his last lecture. But I sat in the front row and I saw the whole thing. It was very special. And he said again, he talked about his experience and why he changed the definition of centric relation over the 40 years in practice. It was just so inspiring to sit there and see a man who created a definition, and he changed his own definition 30 times, guys. He changed his own definition. That really inspired me. And during that time, at this meeting, I sat on the front row watching Pete, and next to me was this man right here, Mike Cantrell. Okay? It was fun. And I'll tell you a little bit about that. So Pete showed this on the screen, and then I called the committee and I said, I really love, the photos, and I called Pete and I said, can I have it for my lecture, because it's got such a beautiful slide of the TMJ and all that, and I love what he said about it. Centric relation refers to the jaw position where the condyles with properly positioned discs are in the most superior position in the fossa. I feel like this is important for me to know, and I wanted this slide because this was the last slide that Pete presented. It was very special to me. It is comfortable. It is a comfortable, unstrained position. The medial pole of the condyle is braced against the medial wall of the fossa, and the lateral pterygoids are released. Okay, so I love this, and the reason is because I think we're about to change Pete's definition of centric relation. Again. Us in this room, okay? And he's gonna be smiling down on us for doing it. There's me with Pete and Joan. I've been his little baby since 1999 when I graduated dental school. And I met Mike there. And the reason Mike and I got together is because of this man right here, chiropractor. See his teeth? We sat in the front row, and you see him here? He's not on a podium because this man was pacing back and forth the whole time speaking. He was just pacing back and forth. Mike and I are there speaking, and he's walking like this. And he only turns one way, and he's spitting at us, and you could see the spit. And I said, Mike. I didn't know Mike, but I knew he was, I heard that he was into this posture thing that I was kind of curious about. And I wanted to impress him that I'm a good dentist, that I know my stuff. And so when he was walking and spitting, I was like, hey, Mike, you know why this guy's spitting? And he goes, tell me, what do you think? And I said, well, whoever made them those veneers, number one, they're too white. This picture doesn't show it, but I'm telling you, they were bright white, okay? And I said, I bet you the dentist didn't work out his incisal edge position, and they violated the envelope of function. And I spoke all these really sophisticated words, and I said, he's probably got it, all this stuff, and now he's violating that, and he's trying to retrude his jaw, and he can't say his S's because the length is too long. And I went on to this whole explanation, and Mike goes, I disagree with you. I turned over and I was like, do you know who I am? He goes, no, Alice, you watch. When he walks, he only turns to the left. He can't turn to the right. Okay? Just watch. Why would he if he's walking this way, I can see him turn to the left, but if he walks this way, why wouldn't he do this? He said, I bet you he can't, because it hurts his hips. Look at how his hips are. And you see he has this calcaneal whip. And I was like, what the heck is a calcaneal, right? He's got this calcaneal whip on his right foot, and his left hip is too flex forward. It's causing him to arch his back. He's having trouble breathing. This man can't sit without without having to move because he can't find the ground. He's way too far on his toes. Just look at him. And I'm like, I can't tell he's on his toes. He's got shoes on, right? And he worked his way up, and he said, you notice when he turns around, look at his shoulders. He's always leaning one way because his shoulder's high up. And he said, I bet you, and look at his neck. He's got too straight of a neck. And when he speaks, you can look at the level of his eyes. He went to all this hole, and he said, because of that, it caused an interference on a posterior tooth, which pushes his jaw forward because of his neck position, and that's why he's spitting. He worked the way up. And I was like, I've been having this really bad pain on my foot for the last 15 years. Can you look at it? You know? So he and I went, we went from there, and we went outside, and Mike goes, let me see your foot. So I took my shoes off, and he touched my foot. We became friends ever since that time. He says, Alice, here's my card, come see me. But right after this one, we came back in, and Dawson had his last lecture. And, sorry. Where did I go? Sorry. So anyways, we have to sit through again. I pressed the wrong button. So when I went to meet Mike in Atlanta, that was February. I was in Atlanta to see Mike by beginning of April, within 2 months. Because I got really curious at that time, and he and I got to meet, and I learned so much from him just talking to him through that weekend. And he, oh, there we go. Okay, so Mike is the one who came up to Dr. Dawson, and he says, Dr. Dawson, what about the fossa? And Dr. Dawson says, what? Who are you? You tell the story. What did he say? What did he say?
I was just curious. I was wondering, he was speaking about the condyle and the relationship of the condyle and the disc, but he didn't take into account the fossa. So I had to ask him.
None of those definitions you saw, there was the word fossa at all.
So I just asked him, I said, are you taking into account the fossa? Because the fossa is a moving target. So how could you have relation of a condyle and a fossa that's moving all the time and not have the mobile fossa in the definition? And not the Mufasa, the mobile fossa in the definition. And I don't know, he looked at me like I had lobsters crawling out of my head. And I just said,
he's like, who are you and what do you do? I was standing right there.
I said, well, I'm a physical therapist, and I don't know, I look at this kind of stuff and it interests me. And then he asked me if I knew Mariano Roccabato, and I said, yeah. And he goes, well, I work with Mariano Roccabato. And I said, he's great. He's a good orthopedist. He's a physical therapist, and he's an orthopedic certified PT. And I said, but this isn't an orthopedic problem. This is a neuropulmonary problem. And every time that person takes a breath, that fossa's on the move. And if we don't account for respiration when we're talking about centric relation, we got a problem. And then he gave me a card, and he said, I want you to call me.
No, you also said before he gave you a card. He said, Pete, I know you've changed his definition 30 times, but I think it needs to be 31 times.
I told him he's going to have to.
And he was like, what?
Yeah,
That's when he said, who are you? You remember that? And I'm standing behind him going, oh my gosh, I don't know him. I don't know him. Do you know who this is?
Yeah, but I was just dumb enough to say no, really I don't. And but I knew that he obviously knew.
It was his first time ever at a dental meeting.
Yeah, it was kind of fun.
So he didn't know who Pete was.
Oh, wow.
But I know that thing.
Now he knows what Pete knows. He's like, oh my God.
Right, but I just had to. He was excited, and I really loved. He used that term "blood on the walls," And he kept saying every time we changed the definition, we'd have to go into a room and argue, and there was blood all over the
Yeah,
wall.
he kept saying
By
that.
the time
Uh-huh.
we finished it, and I was like,
The definition gets changed.
we might have to have another bloodletting, sir, because this definition's not right. It's not right. And then that's when he was looking at me like I was crazy. You're right, I forgot.
Yeah. But he invited Mike to come meet with him. And then
he passed away.
he passed away in less than 6 months after that. So we never had an opportunity. Which tells me that if you know Pete and you know what he's about, he wants us to carry this torch. And I'm telling y'all, this definition has not been changed. But if you're here and you're interested in this work, I invite you to come with me and let's figure this out together and let's change this definition and really help patients from head to toes. So I learned, from taking classes at PRI that the maxilla, the temporal bone, and the sphenoid bone, this butterfly-looking thing, are big deals because the cranial plates have micro movements. Cranial plates have micro movements. I didn't believe it because I was told that cranial plates are fused, but they don't. And that's the reason why our facial features change. That's why your patients come in with one eye higher than the other. They didn't look that way when they were younger. How the heck did that happen? Because cranial plates move. So that's, I hate to drop the bomb on y'all, but it does. If you don't believe me, you will by the end of this course. So let's go back to the future. I'm going to give you a sneak peek, and then after the sneak peek, tomorrow we're going to dive into this, and you're going to get to see what's possible. Sneak peek. Today, my oral appliances no longer is this. I still make this, but I'm also very interested in this. I'm also very curious about the DNA appliance, Vivos, AGA, all those appliances. I'm very interested in MSE. Todd is pretty much one of the top people. Todd and John have done a lot of cases, one of the top, most experienced people in the country. So if you guys are interested in that, he's amazing with his surgeries. You guys all know that already, but he's put a lot of work into doing very well done surgical rapid palatal expansions. Okay, there are people that really, really need it, and Mike will show you tomorrow on some of those. But we have to be cautious because these, no different than before being a single tooth dentist, right? You do anything to the tops of your teeth, it's going to change the jaw, possibly change your jaw position, the joint, the face, the neck, all the way down. So we start changing cranial plates. What's going to happen to the other cranial plates? What's going to happen to your ears, your eyeballs, your ability to find the ground? Neurologically, orthopedically, we know we can do it and do it really well with all those appliances. With the best surgical skills, orthopedically, we can do it very well. We have what it takes. Do we know neurologically what that involves? Okay, the same way, do we know anything about tongue clipping? Because after tongue clipping, sometimes you get patients that go into a panic attack. Have you guys seen that? If you haven't done enough tongue clippings. Rachel? Where's Rachel? You seen that? What's that about, right? So I know you guys have some answers. When we go around the room, we want to hear about that because we have ways of, how with with tongue clipping, you got to get into a myofunctional therapist to prepare the tongue, and then you do the clipping, and then afterwards it goes back to the myofunctional therapist so that you can get relapse. Right? So because there is some muscular neurological responses that's occurring with the tongue. And Christy is supposed to be here, and she'll be here tomorrow. She's got a family emergency that she's tending to, but we're going to have a panel at the end, and we're going to dive into all of this together. So if you guys have questions about that, it would be a really great panel discussion. But obviously there's more to it than an orthopedic procedure. because we're causing neurologic changes. And believe it or not, it also causes cardiac changes. Yeah, we'll talk about that. But anyways, this is not a simple expansion of palates. It's not as simple as you think, and we have to approach it cautiously. Can we be successful with the modality that we are? Absolutely. But we need to be aware of the pitfalls, because if we aren't, we're going to introduce issues for the patient, and that patient's going to come back and blame you for certain things, and you're like, it's in your head. That's not a jaw problem. The minute you start thinking that, you remember this moment in this room where I'm telling you it's because you're not considering the neurological component, okay? And I get experiences like this, okay? I've never had an experience like this with splint therapy for the 20 years I was doing it. But this is a patient, a TMD patient that had gone to 3 other TMD specialists and couldn't get resolution. And the splint that I make now is drastically different than what I used to make because of the way that the material we make it with, the way we set it with, the type of bite record I take. It's nothing like I ever learned at Pankey. I don't take CR bite records. I take body postural bite records, neutral body bite records. And so anyways, watch what she has to, watch her experience. So what happened here, I'll give you a prelude to what happened before she wore the splint. She wore the splint, went home, did well. It was only overnight. She came back, said, oh my God, everything feels great. She comes in to see Mike, and Mike's doing some testing on her. One of the testing is called HGIR, humeral glenoid internal rotation. And a lot of you know that. It's that arm thing that he does, right? And so she had a bunch of limitations in her shoulders. And Mike had, she just got through talking to Mike, and you can see there's a tissue right here. She just got through crying because she has so much anxiety that she's suicidal, okay? And so we have essential oils. So we put essential oils, the anti-anxiety stuff, got her calmed down, and then Mike started doing testing on her, and she failed every single test. And then he says, now I want you to put the splint in, and let's see how you do in the test. And so that's where we're at with it.
It's showtime. Because what I want to do, so we're going to see how good.
Tap, tap, tap.
Look straight ahead, do a couple of taps, and tell me where you're hitting. I can smell the
Smell what?
the oil.
The oils.
Smells good.
Oh,
And I'm
okay.
kind of enjoying it. I'm mooching off of you. All right, so when you're tapping, where are you making contact as you lay there? Beautiful,
Okay.
beautiful. That's where you should be making contact.
So she was really limited there before.
90 degrees here.
Now I'm hitting there first. Look at that.
Well, that's kind of weird.
That didn't do that a minute ago. No, but
Lay
but
it out. Lay it on your chest.
now tap, tap. Well, now it's getting here first.
That's kind of weird. Put that thing back in.
Tap, tap.
That's so weird. Why are you doing that?
Did you see that? Really weird.
Let me borrow your cervical axial rotation. So,
You guys are going to learn how to perform all these tests on your patients tomorrow.
30 degrees of cervical axial rotation with splint.
That was forever. Wasn't it?
Oh yeah.
She's not even sure herself.
Let's
Right?
check her cervical lordosis. Okay, so now she's doing lordosis. This is the best neck I've felt in the last 2 days.
Yeah, I know.
Yeah, so best neck. You get best neck award. So,
I
but
worked
you
on
have,
that.
but you have shitty neck when your splint's not in. So you go from shit neck to great neck.
Tammy. Tammy's like, I'm gonna go hide under a table.
With
I
us.
spoke to her.
I'm not great at bedside, okay?
She felt it. She felt it right away.
Is your splint an orthopedic device or is it a neurologic device?
It appears to be both.
Thank you. So the answer is yes, Is it orthopedic or neurologic? Yes. How about this? Is it an orthopedic, neurologic, or pulmonary device? Yes. Yes. So all we have to do is dovetail you with the glorious work that that splint is doing right now. This is like best of the best in the last 2 days.
Yeah. So that's what's possible in your hands. All of you guys can do this. I don't want to be alone at doing this. I can't do this because we have so many patients. My next available visit is in April. So I really invite you guys to join me in this effort. It's amazing work. Can you imagine just the amount of effect that you have on people? So what's possible? Mike, tell them about this kid.
So this kid, he's hilarious, this kid. I saw him in Atlanta with a dentist, a friend of Alice's that I work with there. And we initially saw him, he had a lot of issues with learning disabilities and attention deficit disorders, this sort of thing going on. And at the same time, he had a fairly significant, I don't know the dental talk for all of that. You guys can tell me what all that is, but pretty squirrely to me. And so we initiated a program of splint therapy, a lot of posture-based work,
Breathing.
work, and teaching him how to shift his center of mass left and right. Put him in an ALF, an advanced light wire functional appliance, and then in a couple of years, through his growth spurt, you can pop that. There he is. So and this
Zero orthodontics.
What?
Zero.
there's no ortho-
Just breathing, splint, and a little tongue
tongue-
trainer.
This is a myofunctional therapist dream patient right here. And then the myofunctional therapist would
We need the myofunctional therapist.
Myofunctional therapists
Yeah.
can teach patients how to have a tongue that can lateralize left and right, to teach that tongue how to not be as scoliotic as their spine or as his face. And if you can derotate that face and derotate that tongue and teach that patient how to manage that system by managing the entire system, shifting his center of mass from right to left and back through neutral, back to right again, that myofunctional therapist becomes a freaking black belt. And so, and that'd be such a case for the MFTs. They can rock a case like that.
Yeah. Isn't that cool? So the journey from single tooth to total body approach. Single tooth. Occlusion aware. Full mouth anesthetics. Occlusion proficient, full mouth anesthetics. Head and neck aware, TMJ, sleep, airway, myofunctional therapy. Then you become head and neck proficient. Next step is posture aware. We're hoping many of you are already posture aware, and that's why you're interested in this course, and that's wonderful. And then at some point, posture proficient, so that we can take a whole body approach to taking care of our patients. In this scheme, this timeline, or this journey, where do you stand? And where do you want to stand? I still think about Karen. What do I do now that I didn't do before? You know what? I look back, those same x-rays, those same photos. This is an upper split. I can't affect her with an upper splint because the maxilla has a suture. And when she walks and she breathes, that maxilla actually moves. So I already lost the minute I made her upper splint. Next thing I didn't see, that tori. That got there, and then she's got a really deep, a real steep, palate. I didn't even bother looking at her tongue. To this day, I don't know if she's tongue-tied. Obviously, there's a tongue issue. Now I see it, right? I look at her face. Do you notice that this cheek is more prominent than this cheek? She's beautiful. But look at this chin. It is, do you see this? Her ears. Do you notice you see one a little bit more than the other? Mike, you tell me. What else do you see? Because you see more than I do here.
So she
Oh,
got-
look at her eyes.
Yeah, her orbits are not symmetric. The left eye right now is slightly lower than the right, and the left zygoma is coming to us. It's closer to us than the right. The mandible's tracking right. Her left ear appears a little bit lower, but I don't want to hang anything on the ears because she could be tilting her head a certain way. What I see here, though, that really bothers me is the picture on the far right.
This is her last year. I stalked her on Facebook and wanted to show y'all. Because I want to see her face over time. I still look at her because I still want to know, what did I miss? But
She's
look at the
taken-
difference.
She's taken the right orbit lower.
Look at the cheek.
Look at the cheek, it's more prominent, and the right
Look at
orbit
that chin.
is drifting down. So that's creating a totally different strain.
Look at
pattern.
this.
And that's a right side bend rotation strain pattern in that far right side. Here, she's a left side bend rotation. At least we think she is.
Mm-hmm.
And somewhere within
It's
that,
hard. We don't have really good visual, but you know, you look at it and you know this looks worse. And to me, this person looked relaxed. She looks strained. I bet you she's still in pain. I'm grateful that she didn't go and do full mouth rehab and to open up her whole bite because that's what she was told she needed to do. Okay. So I mean, this was one more recent. I was like, okay, good. She didn't go crazy with that because she would be in a worse place.
But Alice, I would just be quick to say, you know, we can look at the images and that's fine. But you would have to take someone like that and, like that video of the young lady.
Yeah, we'd have to test
You
her.
have to put them on a table, because this is subjective, us looking at it, because you might be looking at it going, well, I didn't see what he just saw, I saw something different than what he saw, I didn't see that. And you may convince me, I might go, well, what did you see? So it's subjective, but if we put them on the table never lies. You examine them on a table, or even in a dental chair, that doesn't lie.
This was 2007. This is 2017. 10 years difference. So, I don't know. Hopefully I can bring her back and do something. So, she's the one that just makes me think at this point to move in the direction that I'm moving again. Are you a dental mechanic or a doctor? Are we fixing teeth or are we caring for people? And what drives us in either direction? Thank you. So we're going to give y'all a break, and then we'll come back and we'll do a check-in. And I'll write this up there, but we'll go over some things and we'll share and set you guys up for tomorrow. Okay?